thank you. So I appreciate that I'm last on and people's trains will be waiting to go. So I've got more slides than I need to use, but I believe that you will have access to those so that it'll give you more information than you need and you will be able to get in contact with me should you wish to. But first of all, I wanted to ask those in the audience who have heard of the Academic Health Science Networks. Gosh, that's brilliant. And the Patient Safety Collaboratives. Brilliant. Oh, well, my talk is done, actually. Thank you. So for the few that haven't, then we were set up in 2013 in response to a government report which criticised the fact that health and social care made it very difficult to work with industry and academia in providing and producing innovative solutions for health and care. And as a result, industry were tended to leave the UK with their products and their economic growth and go abroad. So our government wanted to persuade industry partners to stay in the UK and to work with health and social care to provide solutions, technological solutions, innovative solutions that may be useful to us. As part of the NHS, there are 15 of these centres in England. And what's probably not helpful is that we all call ourselves something different. So we might call ourselves HIN, for example. So that's Health Innovation Network in London, or UCL Partners. But we're all academic health science networks. And I'm just going to tell you a little bit about what we do, and I'll move on to the safety aspects. First of all, I want to say whether we're an academic health science network or the Patient Safety Collaborative, which is a programme within the AHSN, patient safety is a central priority and guiding principle for all the work we do. We are supportive of the NHS Patient Safety Strategy, and we believe we are a key delivery partner, and we want to support NHS, EI and Aidan Fowler in particular to deliver this strategy in the most economical and effective way we can. So we will support the insights, the involvement, and particularly the improvements. So I want to talk to you mainly about some of the improvement projects that we've been doing. This is the ambition of the NHS Patient Safety Strategy to save up to 1,000 extra lives and £100 million. You might argue that's not ambitious enough, but it is a realistic figure given the amount of spend that we have currently available. So, for example, the Patient Safety Collaboratives have £7 million across 15 across England to help support the delivery of the NHS Patient Safety Strategy, which really is a drop in the ocean. That's our vision. So we will not only support that ambition, but we will try and exceed that ambition by working in a collaborative space and working with our academic and industry partners to accelerate innovation and the adoption and spread at pace and scale of those innovative products, such as WireSafe, which is one of those. This is we have a patient safety plan, which is our ambition across the AHSN network, not only just to support the NHS patient safety strategy, but to go further than that. And these are our ambitions. So I want to give you a few examples of some of the patient safety work that we've been doing across the Academic Health Science Network. So PRECEPT, a long acronym for the use of magnesium sulfate in preterm mums to help prevent cerebral palsy. This was tried in the west of England. All their maternity and neonatal units developed a way of delivering PRECEPT as a programme, the giving of magnesium sulfate to preterm mums in a standardised way. So they understood the quality improvement methodology approach, they understood how much it would cost to deliver, and they worked out the return on investment and the impact of delivering this project. So it was tested in one of the 15 academic health science networks, and then it was spread across the whole of England. Emergency laparotomy, again, started in Kent, Surrey and Sussex Academic Health Science Network, partnered with 2 other AHSNs and tested their methodology by implementation of a care bundle to improve the outcomes of patients undergoing emergency laparotomy surgery. And then this was spread across all 15 AHSNs across England. We have work in medicine safety too, so transfers of care around medicine or TCAM and PINSA, and you heard Stephen Campbell mention PINSA earlier on. So, and we can track and monitor the spread, the uptake of these programs, and the impact that these are having. We're doing some work around physical deterioration. Many of you in the room will be part of that work. This is about the introduction of News 2, a standardised scoring early warning score to detect physical deterioration, validated for use in acute and ambulance sectors. So last year, our ambition was to spread that tool as a standardised way, using a standardised approach to language around the recognition, escalation and communication of physical deterioration to all ambulance services and 100% of acute trusts. And to date, so we've been very successful. All 10, excluding the Isle of Wight, have adopted, ambulance services have adopted this, and almost all, around 98% of acute trusts have adopted News 2. And for those who haven't done so yet, that's 2 or 3, there are severe challenges in the system around electronic systems and reconfiguring those and how much it's going to cost. Some of the clinical risks about changing from one early warning score to another, for example, and the retraining of staff. So the ambition is to be 100%, and we will be there by March this year. It's all right having a tool, but you need to know how to use it, how to escalate and communicate your concerns. So we're also working with the ambulance trusts and acute sectors to work on those aspects too. But we're not just working with acute and ambulance sectors, we're working across the whole system. So we're working with care homes, out of hours, GP surgeries, prisons, etc., in order to try and standardise where possible these tools and the language and processes we use to identify and escalate physical deterioration. And in some cases that won't be using the same tool because it's not appropriate. So, for example, in residential care homes where it isn't usual to take physical observations, and maybe the staff may not have the resources to do so or have had the training to understand how to do so. So other tools will be used, for example, Restore 2, or the use of soft signs. And soft signs are behavioural changes in those residents. So are they sleeping as well? Are they eating as well? What's their mood change like? And these will be the soft signs that will be escalated to a healthcare professional who will then apply the News 2 by taking physiological observations at an appropriate time. So this system-wide approach is really important because patients don't stay in one area, they move from areas, and therefore we need a communication, a standardised language, a way of doing things that, where possible, is consistent. We can also track and monitor some of the impacts. So the Suspicion of Sepsis Insight Board, this was developed by Imperial, AHSN, has now spread across the country, is one way, and I'm not sure how many of the people in the room are familiar with this or use this in your trust, but it is a way of tracking the prevalence of sepsis and breaking it down to disease groups, so sepsis caused by pneumonia or UTIs, for example, and you can track your length of stay, your cardiac arrest rate, your critical care use as a tracking measurement. We've also do a lot of work with our care home sector. We realise that there is more impact in this sector than perhaps the acute sectors now. For a small amount of investment, you get really big impact. And we have just published a roundup of all the work that we're doing across the 15 AHSNs, which demonstrates a huge breadth and scale of work within this care home sector. So to share with you just some examples of impact. Starting on your far left, the standardised benchmarking tool for care homes, which we refer to as LPZ, has an economic evaluation, a healthcare economics evaluation of huge savings just by reducing pressure ulcers within the care home sector. Safety huddles aimed at falls has a return on investment of giving £2 back for every £1 spent. Mental health, emergency laparotomy, catheter-associated urinary tract infection collaborative managed a 30% reduction in UTIs across participating trusts, etc. So these are local projects that are tested at a local level, and then when they've had rigorous testing, they then are spread across the remaining AHSNs so that we can realise impact at scale. So here's an example of managing deterioration, which I spoke about before. I think the important thing here are the circles at the bottom. So that is the widespread use of standardised tools for the recognition of physical deterioration. And the numbers in the circles are the number of patient safety collaboratives working in that sector. And you can see from this chart the inflection point where academic health science networks became involved in the spreading of precept, and you can see that the uptake has risen, so increasing to nearly all the maternity units now, and hopefully an estimated 24 cases of cerebral palsy could be avoided and a lifetime of suffering for individuals and families. Again, with the emergency laparotomy, when the AHSN picked this up as a spread project, you can see the increase in uptake and the benefits and impacts associated with that. The same with TCAM and the same with PINSA. We're seeing now that a number of trends in the use of PINSA. So this is using primary care data, so evidence-based indicators. And the one that we're seeing real impact from is the use of drugs that cause gut irritation or gut bleeding. So this program allows us to work with GP practices to introduce quality improvement methodology to improve on those areas. So the AHSNs are all about adoption and spread. So when we have tested or supported in innovation, it's about how we then spread at pace and scale. Within the AHSN, I've mentioned the Patient Safety Collaborative, and we have a number of programs. Now, the nomenclature or naming of these programs are changing at the moment with the merger of NHS England and NHS Improvements. So some of these terms may be out of date very shortly, but the National Patient Safety Improvement Programme at the moment consists of preventing deterioration, medicine safety, maternal and neonatal safety, and the adoption and spread of tested interventions. We're hoping that we will be able to support the new programmes coming on board around safety improvement in care homes and safety improvement in mental health too. So I've talked about deterioration. Medicine safety, this is part of the National Medicine Safety Improvement Programme. We're focusing on one area of that, and that's the administration of medicines in care homes. We've just finished a 6-month scoping exercise, an in-depth evaluation of some of the issues and challenges that are faced in care homes and the surfacing of some promising interventions that we will start to test and spread. Maternal and neonatal safety is part of the National Maternity Transformation Programme and our contribution to that. And adoption and spread of tested interventions is around things like precept we've mentioned, the Emergency Laparotomy Collaborative, the COPD Discharge Care Bundle, and the ED Safety Checklist. We're also supportive of research and innovation, and we've worked very closely with our patient safety research translational units and our academic partners to identify a pipeline of research to innovation to spread. And of course, we're keen to support all the work around never events as well. So we've been actively supporting the spread of WireSafe. And it's interesting what a fantastic product that is, yet there still is a great deal of resistance to using that product. So when we've been out on the road showcasing this product and asking clinicians why they're not using it, some of the reasons are, I've never left a guide wire in, so I don't need to. Rather, they don't know they've left a guide wire in, probably. This is expensive. Why spend more money on this box when you don't need to? And the third reason was we've got a checklist that works fine for us, so there's no need to change, and that's free. However, when you speak to clinicians who have left a guide wire in, they would adopt this straight away. they absolutely see the benefit, and they've gone through the pain of leaving a guide wire in and all the consequences they faced and their patient faced, and they don't want to repeat that ever again. So it is interesting when you try and spread innovations, some of the resistance you need to work through and help support individuals and organisations in the adoption of that innovation. And again, the other one that Marianne also has invented is the NIC, or the non-injectable arterial connector, which prevents you injecting anything into an arterial line, which of course would be dangerous. So you can only withdraw blood from the arterial line. And again, a simple solution like that, hugely effective, but also has barriers to adoption, which need to be understood and supported to overcome. And that's what we help do. So we do have a patient safety and partnership, a safety plan. Please do look at our website if you want to know more, or contact me at any time. And I'll leave it there.